Hello friends, welcome back to Endo Tales from Life. In this video, let's talk about the diagnosis and management of the cracked tooth syndrome. So both according to literature and the clinical perspective from what we see in our day-to-day practice, this cracked tooth syndrome is continuing to be a growing problem, which means we are seeing more number of patients coming with this cracked teeth than ever before. So the etiology or the reasons could be when you chew on to something unexpected but very hard and very tiny. So, for example, rice being a staple food in this part of the world, when there is an unexpected hard stone in the food bolus, or when people bite onto something really hard and tiny, this could happen. And also, when patients bite onto ice cubes or people who open bottles with their teeth, these are some of the common reasons for it. What poses a major diagnostic challenge is that the cracked teeth are not, there is no clinical evidence of this crack, especially in the initial days, which is when the prognosis is better. So cracked teeth just looks like normal, and most of the time these patients give clear symptoms of pulpitis, lingering pain, or extreme hypersensitivity, and clinician may miss diagnosing the crack at this stage because what I see often is that when patients do not have a clear evidence of caries or cavity, these people are subjected to something like an orthopantomogram, which does not give you or which does not show you the presence of a crack. So now let's understand the stages of crack propagation. So when there is an initial crack, that's when the prognosis is the best, like I told you, but it is very difficult to diagnose at this stage. But the patient's history and symptoms are the most important thing in arriving at a diagnosis. So when a crack keeps propagating, that's when it becomes a fracture or a split tooth. By then, the prognosis of these teeth are also guarded. So it's very important for you to diagnose at a very early stage. So, according to literature, surprisingly, cracks involving the distal marginal ridge have a comparatively bad prognosis compared to cracks involving the mesial marginal ridge. And also, the most important thing is the pulpal status at the time the crack has been diagnosed. So, when the pulp is healthy or when the pulp is in a stage of reversible or irreversible pulpitis, the prognosis of these cracks when treated has been reported to be very good. On the other hand, when these cracks are not diagnosed at the early stage, when you keep postponing the diagnosis, that's when it ends up in pulpal necrosis and the crack eventually becomes a fracture, resulting in poor prognosis. So, the success rate when treated at the early stage is very good, whereas when it's treated a little late is going to be guarded. And according to literature, all these teeth require cuspal coverage, either in the form of crowns or overlays after your treatment. That is very important for the long-term success. So these cracks, like I already mentioned, is not seen very clearly with the naked eye, but magnification has a good role to play in clinical diagnosis. And what you need to understand is that these cracks, this is one of our articles on CBCT, it's clearly established that cracks, that is the initial cracked tooth syndrome, is not diagnosed based on CBCT. CBCT cannot show these cracks. CBCT can be helpful only when the crack becomes a fracture. So very often I see people sending me radiographs, that is CBCT slides, asking me if the tooth has a crack. Unfortunately, CBCT cannot detect these early stages of cracks. So both the OPG and CBCT is of not big use when you use them for your diagnosis. So how do we diagnose them? The clinical examination is the most important thing. So when it's fracture like this, it's pretty evident during the clinical examination. Like I mentioned, OPG is not of great use. One of the best radiographic tools at this point of time for early crack is the intraoral periapical view. But even that, you can see that in this case, does not show any signs of a crack. So this is where clinicians have to go in for additional diagnostic tools. A simple trans illumination test which can be performed with your light cure unit. Recently, Coltine, Densplay and all the new light cure units also come up with their trans illumination mode, which can be used for identifying cracks. Personally, I'm not a big fan of the trans illumination test. What I rely more in these cases is the cold test or the pulp vitality test. So when a patient's history is also pointing towards pulpitis, that is, they give you symptoms like lingering pain or nighttime pain, it's very, very important to now test the teeth that are in question, as we do not also be able to see the exact crack line. We need to carefully evaluate all the teeth in the quadrant and do the pulp testing for all of them one by one. And when the patient also says, clearly points out to the tooth when you are doing this pulp test, that's when the bite test can come into play. But we don't recommend using hard objects like the tooth sloth or the sticks for doing the bite test, which can again propagate the crack deeper. So what we suggest is to go for something soft like a cotton roll, simple cotton roll, ask the patient to bite on them. And there is this classic symptom of the pain being relieved when the patient bites, and when they open the mouth, the pain starts to shoot up. That's mainly because when the patient bites, the crack, the tooth is slightly splitting, relieving the pressure of the pulp tissue from the pulp chamber. And when the patient opens the mouth, the cracked tooth initially tries to come back to its normal position and causing some pressure on the inflamed pulp. So, like I told you, what's more important is the pulp testing, the bite test, followed by careful examination under high magnification. So, we need magnification above 5x. What I would suggest is at least 10x magnification for you to identify these crack lines. And these cracks are not visible on the surface most of the time. So, once you focus or narrow down to a particular tooth, and this patient also has symptoms of pulpitis, and if you see these mild crease lines at very high magnification, what you need to do is something called an exploratory preparation or crack tracking. When you have to remove the surface enamel, that's when these cracks become highly evident. Now, what is the next step? Once you diagnose that this tooth has a crack, what gives you, or how do you assess the prognosis of these cracks, is based on the pulpal status. So, once a patient has pulpitis, we know that the crack is involved to the pulp chamber. So, after you open it up and when you see fresh blood, or if the pulp is still in an inflamed condition, these are cases, or these are indicators that the prognosis is good. And can also visually inspect the floor of the pulp chamber to see if the crack is extending to the floor. And here the crack is very much limited to the coronal side. So we just do the endo and also relieve the tooth out of occlusion and shield the crack with composite. As you can see here, after the endo, I have given an adequate thickness of composite over the crack to shield the crack. And these cases, we need to go ahead with a cuspal coverage restoration as quickly as possible. Like I showed you this another example of a case where on the pre-op radiograph it looks absolutely perfect, but we can see the crack. And both these cases have the cracks on the distal marginal ridge, but the pulpal status is good, it's pretty much in the pulpitis state. So these are cases where we are going to go ahead with endo followed by cuspal coverage. Another maxillary molar, and this time the crack is on the mesial marginal ridge. Again, you can see that there's absolutely nothing evident. The same patient went to 2 other clinics and they were just given antibiotics, painkillers, and they were just postponing the treatment. And when I just explore the suspected area, you need to believe your instinct after doing careful diagnosis of all the steps that I told you. Then you'll be able to see the crack as we keep doing the access. And when you see vital pulp tissue again, we know that these cases are going to have good prognosis. And a cuspal coverage restoration, my way of doing a cuspal coverage is a bonded restoration rather than going for a full crown. But full crown is also a good indication in cases with cracks. So you can see here this tooth was just protected with a bonded restoration. And in the meantime, the 1 or 2 weeks relieve the tooth out of occlusion, shield the crack so that we protect the tooth from functional splitting forces. So these are some examples of cracked tooth syndrome, that is, the crack has still not become a split or a fracture. Now I'll show you some cases where the crack has become a fracture but which can still be saved. So this is an example, 4-6. Clinically again nothing is seen, but when I slightly explore, you can see that the crack is already turned into a fracture. So again, once you see a split, you need not always go in for an extraction. Here I had to remove the smaller portion of the fracture or the split, and this is what I could see. And then I prepared an exploratory access, and what I could see is sufficient tooth structure, the floor is intact. So again, there is no need to extract these teeth. We can just do endo, elevate the margin, And we went ahead with crowns. In this case also, the distal tooth had very limited tooth structure, so we went for a joint crown to protect this tooth. Another case with the fracture. Now you can see that the prognosis is very bad, because when I see radiolucency on a radiograph in a fractured tooth, that's not good sign. So again, this fracture part is removed. You can see it's almost like a middle split involving a lot of tooth structure, the floor of pulp chamber. So we go ahead for extraction. Also, distal marginal ridge cracks. You can see when the crack line is extending into the root, these are cases again going to be having a bad prognosis. So which we also correlate with the radiograph, which gives you a classic sign of J-shaped radiolucency. So not that it has to go in for an immediate extraction, but like in this situation, again there is a J-shaped radiolucency and a crack, and also a patient has an intraoral sinus tract. So the prognosis is guarded, but the patient is pretty motivated to give a try. So what we do is we do endo initially, shield the crack, and also shield the crack with adequate composite, wait for 2 weeks to see how the patient's symptoms resolve or the sinus disappearance of sinus tract. And once we were able to get positive results in 2 to 3 weeks, then we went ahead with the cuspal coverage restoration. So in spite of having a J-shaped radiolucency, this was treated with an cuspal coverage restoration, and you can see that the sinus tract is perfectly healed, which is a sign of good healing. So that's how we decide about it. In the 2 weeks follow-up, if I had seen no prognosis or no soft tissue healing, these cases, we go ahead with extraction. And one of the mistakes that I have done in treating these cracked teeth is that thinking that these cases can be just handled with composites. So this was a case, again a crack involving the distal marginal ridge. The pulpal status was pretty good. So we just went ahead with composite, and in this case what I did was just a composite shielding, did not give a cuspal coverage restoration, and this patient reported in 3 to 4 months with a fractured cusp. So remember that even if the crack doesn't look extensive, these restorations always require cuspal coverage restoration. And so now let's revise on what we already discussed. If the cracks are not evident with naked eye, so you need to go for transillumination if possible, or like I told you, my preference is to go for high magnification examination, pulp testing, bite test, followed by exploration of the crack. And while doing the exploratory access, if you see pulp tissue that is inflamed, that is the pulp is not necrotic, or there is no periapical lesion, these cases have good prognosis, then it's important for you to evaluate the floor of the pulp chamber and the extent of the crack. And you can see the floor is intact, which is again a good prognosis. And give a composite core. When you do the composite core, always shield the crack by at least 1 to 2 millimeter of composite, which we do it and wait and observe for 1 to 2 weeks for the patient's symptoms to completely subside. And after that, after the endo and the composite shielding, like what we have done in this case, immediately go ahead with either full crowns or your cuspal coverage overlays or onlays based on your choice. So that is what was done here. So not all cracked teeth need to be extracted. You can save them if properly diagnosed and managed. Remember that the stage or the earlier you diagnose this crack, the better the prognosis. And also it's very important to motivate our patients about this diet. Be careful with their diet and avoid such habits of chewing onto ice or eating substances that are very tiny and extremely hard. And once again, let me revise that OPG is of no use, and even CBCT is of not great use in early stages of cracks. And look at the location of the crack and the pulpal status to be assessed. These are the most important factors, and following by pulp test and the bite test, examination under high magnification is the most important thing. So I believe that I've given enough insights about the management of cracked tooth syndrome from a more clinical perspective. Hope this video was useful, and see you all soon in our next video.